Supraventricular tachycardia and atrial fibrillation. Courtney Bonovich, D.O. August 15, 2007, SVT, clinical features. Regular, rapid rhythm. Usually narrow complex rhythm. Arises from atria or atrioventricular nodal tissue above the bundle of his that initiate and maintain the rhythm. Either a re-entry or an ectopic pacemaker above the bundle of his. SVT, pathophysiology re-entry. SVT associated with re-entry is PSVT. Avenue nodal re-entry, AVNR, occurs in 60% of cases. Orthodromic AVNR is antegrade conduction via avenue node and retrograde conduction via accessory pathway. Avenue re-entry via an accessory pathway in 30%. Intra-atrial re-entry SP cardiac surgery after large atrial incision with scar formation. Sinus node re-entry, inappropriate sinus tachycardia, ectopic junctional tachycardia, and non-paroxysmal junctional tachycardia are rare. PSVT, clinical features. Can occur in the structurally normal heart. Can be associated with rheumatic heart disease, acute pericarditis, ME, MVP, and pre-excitation syndromes. Exacerbated by caffeine, alcohol, illicit drugs, hyperthyroidism, diet supplements, herbal supplements, ginseng. Can be induced by POX and PVCs. PSVT, signs and symptoms. Sudden onset and termination. Can occur in patients of all ages. Regular, tachycardia. Palpitations, anxiety, diaphoresis, lightheadedness, chest pain, dyspnea, pounding in chest and neck. Syncope is uncommon. Polyuria if SVT prolonged secondary to release of atrial natriuretic peptide, differential diagnosis. Atrial fibrillation/atrial flutter/MAT. Onset usually in patients greater than 60 years/O. Patients usually have heart disease. Irregular rhythm. Ventricular tachycardia. Patients usually greater than 50 years/O. Patients usually have IHD. Present with syncope and SCD. Wide complex regular rhythm. Abrupt onset. Physical exam. Patient can be diaphoretic, anxious, hypotensive, or even asymptomatic. Prominent jugular venous A wave from atrial contraction against closed tricuspid valve frog sign, emergency care. Get immediate set of vital signs including pulse oximetry, 4O2, monitor. EKG. CKMB and TRO-I, TSH, FT4. BMP. Connect patient to continuous 12-lead EKG. Is patient stable? Do they need immediate cardioversion? EKG. The EKG in PSVT is usually a narrow, regular complex tachycardia. Less than 10% of cases will have SVT with aberrancy. To be discussed later. Treatment. Try a vagal maneuver to slow rhythm to see the underlying rhythm. Carotid sinus massage. Do if no Bruts auscultated and no known carotid disease. Massage for 5 seconds and release. Can also place an ice pack on the forehead. Treatment. Adenosine causes flushing, CP, dyspnea. Half-life is 15 seconds. First-line treatment is adenosine 6 mg IVP. If unsuccessful, give adenosine 12 mg IVP x2. Cause transient avenue nodal block by hyperpolarization of the node. Complications include bronchospasms and VF. Will not work if patient has heart transplant. CIF wide complex tachyarrhythmia. Caution in patients with severe COPD. Adenosine 6 mg terminate in 60 to 80% patients. Adenosine 12 mg will terminate in 90 to 95% of patients. Treatment. Next line treatments. Verapamil 0.075-0.15 mg/kg4 can repeat in 30 minutes. Hypotension can occur but can prevent this by giving CaCl2 10% 4 ml. Not commonly used. Diltiazem 10 to 20 mg bolus then continuous infusion in at 5 to 15 mg/hour. Esmolol protocol. Metoprolol 5 mg 4q5/3. Treatment. Consider cardioversion or venous atrial or ventricular temporary pacing if unable to slow rhythm down with adenosine, CCB, and BB before giving antiarrhythmics. Can also give 4-flecainide, 4-procainamide, 4-propafenone, 4-ibutylide. These drugs can cause hypotension, bradycardia, and are proarrhythmic. Synchronized cardioversion should be used immediately in any unstable patient with hypotension, pulmonary edema, chest pain, or other unstable signs. Required dose is usually small, 50 joules. Long-term treatment. Risk of developing long-term PSVT after single episode not defined. One episode is not indication for long-term treatment. Long-term treatment SVT with no pre-excitation. Verapamil, beta blockers, and diltiazem decrease symptoms in 30 to 60%. Randomized clinical trials show no superiority. Failure on a single drug therapy can try a combo of two or add one a class IC or class 3 antiarrhythmic. Long-term treatment with class IC not recommended, and patients should be referred for catheter ablation. Catheter ablation radiofrequency and serothermal. 95% success rate initially. Less than 5% recurrence rate in the first few months. Complications occur in 2 to 3%. Damage to arteries, bleeding, AVF, venous thrombosis, P, myocardial perforation, valvular damage, systemic embolism, and death, rare. Blocking near the avenue node can cause total block of the avenue node and patient will need a pacemaker. Wolff-Parkinson-White associated Ebstein's anomaly. EKG will show a short PR interval, a delta wave, and a QRS interval up to 0.12 ms. Accessory pathway is the bundle of Kent. Wolff-Parkinson-White has two mechanisms for PSVT. Orthodromic, narrow complex, 95%. Antegrade conduction via avenue node and retrograde conduction via accessory pathway. Can treat like PSVT. Antidromic, wide complex, 5%. Antegrade conduction via accessory pathway and retrograde conduction via avenue node. Do not give digoxin, BB, verapamil. Try procainamide and cardioversion. SVT with WPW catheter ablation is the treatment of choice once stable. Risk of sudden death is 0.15 to 0.45%, year. Wolff-Parkinson-White can degenerate into atrial fibrillation. If life-threatening, do immediate cardioversion. If not unstable, you can try procainamine, amiodarone, or lidocaine. Caution: verapamil, BB, and digoxin will cause degeneration into ventricular fibrillation. SVT with aberrancy occur in less than 10% of cases. Regular, wide complex tachycardia. Causes: SVT with a pre-excitation syndrome. Antidromic reentry seen in less than 5% cases of patients who have WPW. Patient with a pre-existing BBB. Bundle branch fatigue and PSVT. Atrial fibrillation. Uncoordinated atrial activation with deterioration of atrial mechanical dysfunction. Ventricular response to atrial fibrillation depends on the integrity and electrophysical properties of the avenue node. Most common arrhythmia encountered in clinical practice. Atrial fibrillation. Most common sustained tachyarrhythmia patients seek treatment for. Affects 0.4 to 1% of the general population and 8% of patients greater than 80 years old. AF occurring in patient without structural heat disease and less than 65 years/O is termed lone AF. Types. First episode. Paroxysmal, self-terminating. Persistent, requiring electrical or pharmacological treatment. Permanent, atrial fibrillation irregular rhythm. Can be associated with rapid ventricular conduction/response or AF with RVR. No atrial kick in atrial fibrillation. The firing of the atria and ventricles is not synchronized. In patients with systolic dysfunction, the atria makes an important contribution. Biopsies have shown patchy fibrosis of fibers in atria. Foci can be found in atria, pulmonary arteries, coronary sinus. Atrial rate is 350 to 600 beats per minute. Multiple small areas of the atria are firing and contracting, quivering. Ventricular conduction rate is variable 40 to 180 bpm. Causes for atrial fibrillation. Rheumatic heart disease. Non-rheumatic mitral valve disease. Hypertension. Chronic lung disease. ASD. Thyrotoxicosis. Lone AF. Ischemic heart disease. Acute ME. Dilated cardiomyopathy. Holiday heart alcohol ingestion. Theophylline toxicity. Pheochromocytoma. Causes for atrial fibrillation. Pericarditis. Electrocution. Post-cardiothoracic surgery. Myocarditis. Pulmonary embolism. Obesity. Intracardiac tumors or thrombi. Amyloidosis. SA or CVA. Familial AF. Signs and symptoms can be severe. Pulmonary edema, palpitations, angina, and syncope. Relatively asymptomatic. Nonspecific symptoms such as fatigue. Treatment of AF with RVR. Get an immediate set of vitals, pulse oximetry. Place a patient on a monitor and O2. Get 4 access. Get EKG. Check BMP. Check CKMB and try get CXR. Check TSH and FT4. How long has AF been present? Less than 48 hours or greater than 48 hours or unknown. Is patient unstable? Do they need immediate cardioversion? Treatment of AF with RVR rate control. Medications, if preserved F greater than 40%. Diltiazem 10 to 20 mg for bolus and run a drip in at 5 to 15 mg/hour. Can repeat the bolus if needed. Esmolol protocol. Metoprolol 5 mg for Q5 min X3. Treatment of AF with RVR rate control. Medications, if F less than 40%. Recommend. Diltiazem 10 to 20 mg for bolus and run a drip in at 5 to 15 mg/hour. Can repeat the bolus if needed. Amiodarone 150 mg for over 1 minute, then 1 mg/minute for 6 hours, then half a milligram per minute for 18 hours. Caution if patient on digoxin. Watch for hypotension. Low efficacy for acute conversion, treatment of AF with RVR rhythm control. If duration is less than 48 hours and def greater than 40%. DC cardioversion at 100 joules, 60%, 200 joules, 80%. Only one of the following: amiodarone, ibutylide, flecainide, propafenone, and procainamide. Treatment of AF with RVR rhythm control. If duration less than 48 hours and def less than 40%. DC cardioversion or amiodarone. Treatment of AF with RVR rhythm control. If duration greater than 48 hours or unknown. Do rate control. Start anticoagulation for 4 weeks with therapeutic INR. Exclude clot. Do cardioversion. Continue anticoagulation for 4 more weeks. Begin for heparin. T. Exclude clot. Cardioversion. Anticoagulation for 4 weeks. T will show thrombus in 5 to 15% in atrial fibrillation preparing for cardioversion. Thromboembolic events have been reported after normal T and cardioversion. Contrast-enhanced MRI is evolving diagnostic modality for evaluation intracardiac thrombi. Statins have been shown to decrease risk of recurrent AF after cardioversion, possible due to anti-inflammatory effects. Atrial fibrillation. AFFIRM trial 2002 showed no mortality differences between rate and rhythm control groups. Rhythm control should be reserved for patients who are symptomatic even when rate controlled. Patients need either rate or rhythm control and anticoagulation. New onset AF minimal evaluation. H&P for symptoms, type of AF, date of onset and duration, treatment given, comorbid or predisposing conditions. ECG evaluate rhythm, LVH, pre-excitation syndromes, BBB, and Old Me. TT evaluate LV function, clots, inferior, valvular disease. Labs, TSH, renal and hepatic function. New onset AF additional testing. 6-minute walk test to assess for adequate rate control. Exercise stress test. Holter monitor. T. Electrophysical studies. Atrial fibrillation. AFFIRM trial showed that patients despite being in sinus rhythm are still at high risk of stroke. Patients with paroxysmal AF still must be anticoagulated. CHADS 2 criteria recommended that scores 0 to 2 can use aspirin safely and scores greater than 3 need warfarin in those with non-valvular AF. CHF, 1 point. HTN, 1 point. Age greater than 75 years, 1 point. DM, 1 point. Prior stroke or TIA, 2 points. CHADS 2 score, stroke rate per year, percent, 1 2 3 4 5 6 1.92.84.05.9 1 2 3 4 5 6 Stroke rate per year, percent, 1.9 2.8 4.0 5.9 8.5 12.5 18.2 Risk of stroke. Atrial fibrillation is associated with increased risk of stroke, heart failure, and all-cause mortality. 5% per year risk of CVA in patients with non-valvular atrial fibrillation. Framingham study showed 17 times increased risk of CVA in patients with valvular AF and 5 times increased risk in those with non-valvular AF. 1.5% risk of CVA in patients age 50 to 59. 23.5% risk of CVA in patients age 80 to 89. Risk of Stokes-Neha classification, risk of stroke/ear, percent, I23. 4. Risk of stroke/ear, percent. 4%. 12 to 26%. 27 to 50%. Risk of stroke risk factors, relative increased risk, CVA/TODMHTN. HF. Age per decade. Relative increased risk. 2.5. 1.7. 1.6. 1.4. ASA treatment. Treat of AF with ASA is a Class I recommendation by the 2006 ACC guidelines in the following subsets of patients: age less than 60 and no heart disease, age 60 to 74 with heart disease and no risk factors, age 60 to 74 and no heart disease. Risk factors: heart failure, F less than 35%, HTN. Pharmacologic cardioversion. Ibutylide is the only drug FDA approved for pharmacologic cardioversion. 45% conversion rate for AF. 60% conversion rate for atrial flutter. Class 3 agent with a 4 to 8% risk of TDP. Higher if patient has CHF or cardiomyopathy. 0.01 mg/kg, max 1 mg, over 10 minutes. Have external defibrillator ready. Monitor of telemetry for at least 4 hours. Pharmacologic cardioversion. Digoxin and sotalol are not recommended for pharmacologic cardioversion. These drugs gave Class I India recommendations for pharmacologic cardioversion. Dofetilda. Flecainide. Propafenone. Ibutylide. Amiodarone, yeah. Electrical cardioversion. Recommended if symptoms are known to be less than 48 hours. Unstable in patients without accessory pathway. Unstable or in tachycardic patients with an accessory pathway. Patients unable to tolerate symptoms. Contraindicated in hypokalemia and digitalis toxicity. Other treatments: Mays procedure. Can do as an adjunct procedure during open heart surgeries. Catheter ablation after EP studies to determine irritable foci. AVN ablation can be useful in patients with tachycardia-mediated cardiomyopathy. Small study showed increase in F from 26% to 34% after AVN and pacemaker implantation.